The second part of this question is again IEM with a peculiar odor. The session is over. All of you write your name, institution, and hand over the answer sheets.
Creative disorder. The presenter is Dr. Jagadish from ICH. We have two teachers, Dr. G. Kumaresan and Dr. Sitrambalam. Dr. Kumaresan, we are very gifted to have a teacher for him in this session. The former HOD of pediatric neurology in ICH, one of the senior most pediatric neurologists in India, the founder of pediatric neurology in ICH. We are very thankful, sir, for you. Dr. Sitrambalam, urologist from SRMC.
So, good morning. So, Master Satish, 9-year-old boy, fourth born to a second-degree consanguineous marriage, coming from Tiruvannamalai, whose informed his mother, whose reliability is fairly good, presented with complaints of difficulty in walking and history of falling down for 2 years.
We'll stop here. what will be a thinking process? Difficulty in walking and history of falling down. This would mean that there is a problem in coordination. What are the possibilities with this? For example, you can start from a neuromuscular problem. A proximal muscle weakness could produce difficulty in walking and history of falling down. But if you go into the history, there's difficulty in falling down and getting up is difficult, but after that he may be able to walk. Or it could be a pyramidal tract weakness, in which case a frequent falling will be tripping and falling, and the mother will be able to give you history regarding stiffness of limbs. Or it could be ataxia in coordination, in which case a few steps child falls down, but child is able to walk better with assisted. So these two questions, difficulty in walking and falling down, should make you the differential diagnosis. Is it upper motor neuron lesion? Is it a lower motor neuron lesion? Or is it an incoordination? Theoretically, the incoordination could also be due to sensory disturbance, in which case the parents will give you a clue that the incoordination is more in the darkness or in the evening. So these two questions next set of questions we'd like to ask would be the tone. What is the exact difficulty in walking? Is there also a weakness of the hand grips? So that you try to get the distribution of weakness and find out whether the weakness is upper motor neuron or lower motor neuron. Yes, next slide. So with that in question, you'll build up the rest of the history. Next slide.
So history of presenting illness. So most of his complaints started initially. I'd like to start from the birth history. The boy was born by normal vaginal delivery with a birth weight of 2.8 kg term. There was no history of any antenatal problems, but there is history of seizure on the 13th day postpartum. And he was kept in ICU for 15 days, but was not ventilated. And the mother could not recollect much details. But there was no further episode of seizures. He was put on anti-epileptics for nearly 1.5 years. And the mother stopped abruptly, and there were no further episodes of seizures. So developmental history. So he attained his initial head control at 5 months. He was able to sit with support by 10 months and without support by 1 year. He was able to stand with support by 1.5 years and without support by 2 years. And he was able to walk without support by 2.5 years. So the mother could not recollect much details, but what she could tell is there was definitely a developmental delay. She was able to compare with the peer groups, and he was able to walk without support by nearly 2 to 2.5 years. A fine motor, he was able to reach for objects by nearly 1 year, but he was not able to do fine skills like writing, and he attained a social smile by 4 months. He was able to feed himself with spilling by nearly 1.5 years, and able to dress himself by 4 years. Language, there was a delay, but he started speaking few words with full sentence by only 5 years.
Now, what does this indicate?
Sir?
What is your interpretation of this history? Is this significantly abnormal? Do you think it's related to the present neurological condition? That's the next step you're going to say. See, for example, if you examine the child first time at 5 years of age, he's able to walk independently, he's able to reach for objects, he's able to speak full sentences. So at the age of 5, are you going to call him delayed or are you going to call him normal? That's a question which you keep in mind, to see whether this history could correlate with the present neurological findings or not. Because when you come to analysis, the age of onset becomes important. If you think this is significant, the age of onset seems to be very early infancy.
So at that time he was able to...
Because one or two statements they make about is, sometimes you can have a delay in maturation. So that what you make a diagnosis of a development delay or a cerebral palsy, many of these children may outgrow this by the age of 2 years. That's why sometimes they say do not make a firm label of development delay or a cerebral palsy before 2 years of age. So these are the two things you'll keep in mind when you come back for the discussion for possible etiology. Does this mean significant, and does it correlate with the present neurological findings?
So at that time he was going to school, but his scholastic performance is much below average when compared to his peers. He was able to play with the other children, but the mother feels that his development was much delayed when compared to the other children. For the last 2 years...
Right, 1 minute. Now he's 10 years. The history between 5 years to 8 years is missing. Was he static from 5th year or 8th year, or was it slowly deteriorating? Because you
Statics,
need now, if it's deteriorated at 8th year of age, are there two independent diseases or continue over the same disease? That will change your differential diagnosis. So between 5 and 8, he was normal. Or
So,
had a,
mother could not recollect much details, but what she feels from 5 to 8 years, he was almost normal from what he was there before.
you're committed now, right? Though you added the word almost, but you said, but 5 to 8, he has been normal.
For the last 2 years, he was noticed to have difficulty in walking, and there is history of repeated fall when he tried to walk. He was not able to put buttons. There is a history of difficulty in getting up, wearing slippers, lifting objects, putting clothes, and mixing food. The mother noticed stiffness in his body, and there is history of difficulty in speaking.
We'll stop at, I'm sorry, finish.
He was also found to have hyperactivity and behavioral symptoms in the form of hitting mother when demands are not fulfilled. An history of bowel and bladder incontinence is there. Previously, he was able to tell to the mother that he wants to go to toilet, but now he doesn't say those things.
Got the previous slide. So right, now the last 2 months there is a problem. You divide this problem into two sets. He has beautifully put it in two separate slides. One relates to motor weakness. The important point in the motor weakness, your mother has noticed increased stiffness. That would mean it's more likely to be an upper motor neuron. Then the distribution that he has difficulty in getting up indicates your proximal muscle weakness. The difficulty in wearing or holding the slippers tells you that there's a difficulty in the distal muscle weakness. Maybe there's a frequent tripping and falling. Not able to put buttons indicate to you that there is a distal weakness. And you go ahead further, find out the distal weakness. Does he have difficulty in mixing food? Is there a change in handwriting? So these three things would indicate to you the functions of the distal muscle weakness. Not able to lift the hands, lifting objects, putting clothes indicates to you that it could be a proximal muscle weakness. So that one set of complaints indicates that there is a motor weakness. And from the history, it's probably a upper motor neuron weakness. The second half indicates your behavior problem. Next slide. This, I'll have to make sure whether this behavior problem is environmental or part of the neurological deficit. Now, the bladder and bowel incontinence. So you have got three sets of complaints, one relating to motor, one related to higher functions, and bowel and bladder. Now, next step, you should see whether this has come gradually. For example, the whole set of symptoms evolved over a period of 7 days and remained static. Then you could know that it is still an acute presentation with residual. Whereas he developed spasticity, 6 months later he had behavior problem, another 1 or 2 months later he has a neurological, bladder bowel incontinence. That would indicate that this is a progressive disease. That we'll have to establish. It both could be two diseases. One, he had a development delay, static. Then he had a behavior, acute onset of disease following a febrile eczematous illness. Then it's an acute encephalopathy. I'm not using the word encephalitis, acute encephalopathy, which may be viral, could be metabolic. Two separate episodes. Whereas the last 2 years, the symptoms have been gradually progressing, adding one after another. Then it's a progressive disease. At this point, let me also keep in mind that this child had a development delay and has now a progression. Could this still be a static encephalopathy? Can a static encephalopathy deteriorate? Under certain circumstances, they can deteriorate. For example, when there's an increasing spasticity, the motor handicaps could be added on. Or when there's a new onset of involuntary movements. For example, choreoathetosis and a cerebral palsy can come later. New onset of seizures or the presence development of hydrocephalus could alter the pictures. These are the 4 or 5 conditions which could look progressive in a static encephalopathy. The good reference for this is the FENICAL, Pediatric Clinical Examination, which gives a beautiful chart giving the causes. What I usually would like to do is keep a separate notebook for clinical examinations and keep those charts copied onto it. After the theory exam, you don't feel like opening the textbook, but you need certain data regarding for your clinical data, for your clinical examination. So this would mean that you should discuss that there are 2 sets of conditions. If they are going to be related and my diagnosis is static encephalopathy, these will be the explanations. See, most of these discussions you should volunteer and not wait for the examiner to give you structured questions. If you start arguing yourself, then the examiner will feel impressed. And never aim at a correct diagnosis. The usual complaint, I gave the diagnosis correct, yet the examiners failed me. It's not the correctness of your diagnosis. It is your approach or way in which you argue the case. All of us know the correct diagnosis can be easily got from your colleagues. But when you build up the story, you may build it up in such a way that all the points are against the final diagnosis. So you'll have to give the reason why you get it. Do not worry that whether your final diagnosis is right.
So he was able
Yes.
to recognize familiar order, no history of visual disturbances, no history of abnormal eye position or eye movements, drooping of eyelids, no history of difficulty in chewing, he was able to perceive pain over the face, no history of deviation of angle of mouth, is responding to comments even when the mother calls by his side, no history of change in voice or history of nasal regurgitation, no history of deviation of tongue.
The usual thing, what I say during presentation is, all the history is no only. All the 12 cranial nerves you related to no only. So I could say, why don't you give the positive history first, doctor, and the negative history? This I would accept an undergraduate because he has to know cranial nerve 1, 2, 3, 4, 5, 6, 7, 8. Now you could summarize, if you think the cranial nerve dysfunction is important to your final diagnosis, give it a little more expansion. Otherwise, you say all the cranial nerves are normal, and then give a few negative findings which you think are relevant to your final diagnosis. For example, in this case, he has got a spastic weakness of all 4 limbs. Difficulty in swallowing, difficulty in nasal lower cranial nerves may become important to see whether he has got a bulbar or pseudobulbar palsy. Since he has a delay in development, your hearing and visual development may be important. So put all of them in one sentence. Because ultimately the examiner is willing to listen to you only for 30 minutes. So make sure that you condense it in such a way that you highlight the relevant points. And try to bring those negative points lower down. Expand the positive signs first.
No history of sensory disturbances, no history of involuntary movements, no history of worsening of unsteadiness in the dark, no history of altered sensorium or seizures, no history of decrease in head size noted by the mother.
Okay. Does the head size decrease?
Acute microcephaly.
So the correct word would be no retardation of head growth. That you can say only if he has a documented. Operation. Whole thing collapses. That means neurologically he will not be good. Right.
No
Yes.
history of any exanthematous illness, history of head trauma, no history of dog bite or history of injection of rabies vaccine, no history of fever with altered sensorium or seizures preceding the deterioration of this illness, no history of vomiting or headache or visual disturbances.
So you should rearrange it to bring those last 2 negative points much higher up. Right. The history of present evolution should have been little more detailed. When did he have developed incontinence, all the step by step. If you're going to show the evolution step by step, probably you have a differential diagnosis for different hands.
Past history, no
I
history
still remember what Professor Srinivasan used to say. The undergraduate's presentation of a neurological case is much better than a postgraduate. We take the best students, train them to become poor case presenters. I fully agree. Every time when a candidate presents a case, I'll think whether a final year student would do a better thing. Make sure that you don't fall into that criticism. Yes.
no history of jaundice or any other medical illness,
Any other means you avoid such words unless you have something relevant to your history. Right. And you have made one statement that there is no history of visual disturbance, which remains firm in my mind. Okay.
treatment history, he was initially given antiepileptics for 1.5 years, and for the last 1 year he was being evaluated at CMC Vellore, and he was given some oil, and the prognosis was explained to the mother. Family history, and the boy was said to have some neurological problem. Family history, was born to a 2nd degree consanguineous parents, is 4th born, 1st and 2nd children are healthy, 3rd one is abortion. Both the father and mother are not educated.
For an MD postgraduate, little more details about consanguinity. 1st degree, 2nd degree, 3rd degree, and how many brothers and sisters you have. I know there's a difficulty in taking within 30 minutes, but I would expect little more details if your final diagnosis has something to do with a genetically determined disease. If you are aiming to sell something, right? For example, since I know what you have got in mind, I don't want to go back into the details, but I should like to know, family history does not indicate a general statement, is there anybody in the house with similar illness? That may not be adequate. But as you are doing the neurological examination, talk to the mother, how many brothers and sisters you have, how many children you have, something like that. So you say there is no family history. He has 12 cousins, all of them are normal. Something to give a clue to the examiner that you like to know the family history at least for 3 generations. I know it's difficult in 30 minutes to take that, but do not take the history sitting with your hands folded. Do the neurological examination, keep talking to the mother, so that 30 minutes may not be a big difficulty for you.
Birth history, the mother was booked and immunized. No history of exanthematous illness.
Booked is not a good word. Had a good antenatal checkup, right? See, my professor of neurology used to say, even if I close my eyes and hear this is the 3rd child of a non-consanguineous para, okay, this boy is from Madras. Don't follow that trap. She had regular antenatal checkup, right? I didn't want to be that blunt. That's why. Yes, sir.
Took iron and folic acids. No history of diabetes, hypertension, or any other medical illness complicating the pregnancy. The baby cried immediately after birth. No history of neonatal jaundice. He had a history of seizures at 13th day postpartum, for which he was kept in ICU for 15 days.
Right, now let's analyze his history. What is very striking mystic omission is I never said born at term or preterm. See, when you are trying to sell perinatal pathology, term and birth weight becomes very important. So far you have not mentioned, you could say it's a normal delivery, which I mean born at full term, but never forget to mention whether full term or premature. Second thing, what do you think this seizures is due to? Because ultimately I must know whether this seizure is a transient metabolic disorder like hypocalcemia. Does it indicate structural brain damage? What do you think the cause for seizures? What would you label it?
So could be metabolic.
Now, you use a word in which you can escape later. Child had a neonatal encephalopathy. Because child had seizures, child needed hospitalization. In which case, I could still discuss that neonatal encephalopathy could be a hypoxic ischemic birth injury, could be a metabolic disorder presenting as neonatal encephalopathy. Commonest cause of neonatal encephalopathy will be a perinatal insult. But sometimes the neonatal encephalopathy can occur with sepsis, can occur with metabolic disorders. So use the word neonatal encephalopathy, which will give you more space to escape during discussion.
So immunization history, was immunized up to 1.5 years. Nutritional history, he gets 1600 kilocalories as against 1800 kilocalories according to ICMR with a calorie gap of 200, and protein of 220 grams as against 25 grams with a protein gap of 5. Socioeconomic history according
Be
to...
prepared some of the pediatric exam. For example, if I am a pediatric examiner not much interested in neurology, these are the areas where I will probably spend more time. How did I arrive 1600? You should be immediately able to show me a chart. By looking at the chart, I will know how much you are good in taking a nutrition history. So make sure that you are not caught on details. Because in the neurology case, I think examiner may not ask me the details. Don't get caught. Yes. In case if any one of us are not audible or if there's too much of echo, let me know. We'll adjust the volume.
Socioeconomic history, according to modified Kupswamis criteria, they belong to lower class socioeconomic status.
Right. Good.
To summarize, he is a 9-year-old male child born to the second-degree consanguineous parents with history of initial developmental delay, now has a regression of attained milestones with increased stiffness and with no involuntary movements or seizures.
Right. What do you think with this history? After that, I think Professor Chitrambalam will take over for a few questions. You'll have to stand assault, dual assault, right? Okay.
So
What do you think?
There
For
is a
example, the
regression
best
of
way to
attained-
discuss, there are 2 components. One is the initial delay, remaining well for about 3 hours, then there's a deterioration. I like to consider conditions in which both are the same manifestation of the disease or they are 2 independent diseases, right? For example, the development delay, though there has been a delay till 5 years of age, subsequently child seems to have done well till 8 years of age. So whether this is a late manifestation of a perinatal insult or is it 2 independent conditions. I would like to discuss. Then after the physical science, you can give me the facts. I think Professor Chittambalam will ask you some questions on history. So far, what you have done.
No, first of all, I want to give you one correction. 3 places you have used the word consanguineous. The spelling is a little wrong. Can any of you identify what is a mistake in the spelling of consanguineous? Because he has used the word consanguineous in 3-4 places. All the places he uses the wrong spelling. Can any of you identify that? Any missing letter you can identify? E. So, always try to pronounce it as consanguineous, then you will not miss the E. Say Neous, because it's an exam review, you will have to be correct in spelling, right? So it is consanguineous and not consanguineous. Always use one E, right? What was the cause for the seizure, the child? When was the seizure and what was the cause for that?
So the mother could not recollect much details about the nature of the seizure, sir. It occurred on the 13th day postnatally, sir. The baby cried immediately after birth, so probably it should not be any perinatal depressed one. I couldn't rule out any septic cause. Again, metabolic cause also could not ruled out. After initiation of fits, there is no deterioration. On the 13th day only, the child developed seizures.
So that seizure was not worked up.
Sir?
That seizure was not worked up. The cause was not worked up. But this child was given AED for a long time.
1.5 years, sir.
Do you think it is warranted?
No,
Do you think a AED of 1.5 years is warranted for a child with seizures of 13th day of life?
No, sir.
So, because since you are presented like that, the audience should not take it for granted that a seizure coming on 13th day of life, you have to give anti-epileptic for a long time. Here in, first of all, it should be worked up, and if you find that it is a symptomatic seizure, probably the anti-epileptics are not necessary for a long time. If you find this is a seizure which is going to recur, and there is a fixed or structural cause, then or there's a genetic cause, then you will have to continue for a long time. So then, since this seizure was not worked up, a very long AED might not have been warranted. So that is second. Third thing is, this child, you can say the child presented with the features of leukodystrophy. Or where do you think is the lesion? Is it a lower motor? You said history of difficulty in walking with human signs. So you know it's a human lesion. Do you think, where do you think is the lesion? Is it in the, which level of the neuroaxis you think the lesion is?
So it should be in the cortex, white matter. So because of spasticity or any other signs of human features should be there. So upper motor neuron should be involved. Since there is a regression.
1 minute. You have got seizures history, you have got a history of behavior problem and spasticity. If you put all 3 together and said it's cortical or hemispherical, it would have been easy. Don't get stuck. For example, don't you get spasticity in a spinal cord lesion? So spasticity alone does not help you to localize the lesion in the hemisphere because it's associated behavior problem with history of seizures. Second thing, seizures for the first time in 13th day of life. What is your priorities? Asphyxia is less likely, isn't it? You should expect it with the first 3 days. So what is your priority? That's what he wants to know. What is the cause for seizures for the first time on 13th day? Was it first time on 13th day? How many days did it persist? All those details may help you. If it's true that it is the last seizure was 13th, diagnosis is different. Whereas the first seizure was on 13th day, the diagnosis is different. For example, most of the inborn errors of metabolism will come only after you initiated milk feeds and may come after 7th or 8th day. Seizure for the first time or 7th or 8th day is less likely to be asphyxia birth injury. Next question. Yes, sir. Sir, Professor Srinivasan. Okay, that should be your analysis for the neonatal seizures. Now, regarding his question, the duration of neonatal seizures, you should have given 1 point statement that the duration of therapy of anticonvulsants in neonatal seizure will depend upon the etiology, will depend upon the neurodevelopmental sequelae and EEG findings. That's what he wanted to know, the factors, whether you take all the factors into consideration during the duration of therapy of neonatal seizures. And further, if it's a transient condition like hypocalcemia, it may not require, and neurological development is normal, it may not require long term. So the way of putting a question is to see whether you'll be able to give me that answer in details. The duration. So, Professor Srinivasan, sir. Sir, Professor Srinivasan, sir. He can come and sit. Okay. Yes. So our third question is, when does hypocalcemia present as seizures?
So early onset hypocalcemia is
Right. Early, other one?
late onset hypocalcemia.
Right. When does the late onset comes?
So third day, so 3 to 5 days.
Okay. That, for example, for a 13th day seizure, you would say, late onset hypocalcemia could be a possibility. Okay.
So examination.
And unfortunately, I don't think we take the history of vitamin K injection in the newborn period. Because one of the possibilities, late presentation could be a hemorrhagic disease of the newborn.
So before you go on to the examination, now you know that the child presenting with developmental delay and spasticity, because the child has stiffness and with the regression of milestones. So at this stage, what are the differential diagnoses you will consider? Because in neurology, most of the diagnosis is made at history, and only a small revision can be done with an examination. So at the end of the history, with a child with developmental delay with regression. So you have all the three terms: developmental delay, developmental arrest, and developmental regression. Here probably you have a developmental delay with developmental regression. And the one definite sign is a spasticity involving all four limbs, is it? At this, and with no definite history of seizures, with no definite reduction in the head size, and with no definite visual disturbances. So all these things you have mentioned, and with mild behavioral disturbances with no definite history of dementia, right? So with all this, what are the differential diagnoses that you will keep before you proceed on to examination?
Since there is a regression of milestones, attained milestones, I want to put neurodegenerative as the first probable diagnosis. Because some neurodegenerative disorders may have an initial developmental delay, and they have their onset even during the neonatal or infantile period. So also I want to rule out other causes of regression of milestones, like any space occupying lesions or any hydrocephalus. All these things also can cause a regression of milestones.
So but there is a background history of mild developmental delay which got aggravated probably after the age of around say 5 years, 8 years. So with this, any differential diagnosis you want to keep, list of differential diagnoses you want to keep in mind before you proceed to the examination?
So first thing is neurodegenerative disorders.
That's a huge chapter.
Sir?
What are the neurodegenerative disorders that you will like to keep in mind?
So in that, among the white matter disease, I want, because it presented with the spasticity, with no much of dementia, but some behavioral.
So now you have
disturbances
decided it's a leukodystrophy. How do you differentiate a leukodystrophy from a poliodystrophy? What are the classical differentiating features between a leuko and a poliodystrophy? That is a white matter and a gray matter disease. List out the definite differences between a leuko and poliodystrophy.
So disturbances of tone.
What is the age of onset of either this? I will give you some clues.
So again, leukodystrophies, early infantile, neonatal onset is there, infantile, and late infantile onset is also there, sir. Among the leukodystrophies, if there is a white matter involvement, there will be disturbances of tone, gait, spasticity, and dementia, psychomotor.
No, among leuko and poliodystrophy, which one usually presents earlier?
So leukodystrophies.
No, but usually poliodystrophies present earlier and leukodystrophy little later. And because poliodystrophies involve the gray matter, they present much earlier than leukodystrophies. Then what are the differences you know between, because at this point you want to differentiate between leuko and poliodystrophy. What are the other differences between leukodystrophy and a poliodystrophy?
Dementia, seizures, and psychomotor disturbances will be more in case of gray matter disease.
So dementia will be early, severe in a poliodystrophy compared to a leukodystrophy. Then
Seizures, history of
seizures are early, frequent, severe in a poliodystrophy. Seizures may be present but not so severe or so early in a leukodystrophy. Then
Psychomotor disturbances will be more in gray matter diseases. But still, some leukodystrophies will also have behavioral.
yes, at the end all get mixed up. At the end you will have both the features. But initially during the presentation, yes, then
Visual disturbances will be more in gray matter diseases.
visual disturbances are more in gray or white.
I mean, it can occur
Now,
in
if
both.
at all you have a visual disturbance in a gray matter disease, what will be the feature? If you have a visual disturbance in a leukodystrophy, what will be the feature?
So usually in gray matter, pigmentary changes like retinitis pigmentosa will be there, whereas in case of leukodystrophies, optic atrophy will be there.
So how do you remember that? You can remember that the gray matter is one which has the cell bodies, and the white matter is one which has the axons. If you apply this to the eye, you have the you have the axon, you have the neurons in the retina, and the axons only form the optic nerve and the optic disc. So the white matter of eye is optic disc, and the gray matter of eye is retina. Remember like that, right? So if you have a poliodystrophy, classically you have a retinal degeneration, and if you have a leukodystrophy, you have a classical optic dystrophy. So if you are going to proceed in this case, you will have to be very cautious in looking at the eye. You want to know whether it is a gray matter of the eye or a white matter of the eye. So you can see whether it's a optic dystrophy or a poliodystrophy. Any other differences are there? What about cerebellar signs? Where do you have more cerebellar signs?
So peripheral neuropathy and cerebellar signs will be more in white matter.
Because they are all more white matter. The peduncles are all white. The cerebellar peduncles are white matter, and you can have peripheral neuropathy in a white matter disorder, because again you can remember the central nervous system axons and the peripheral nervous axons are peripheral nerves. So you can have, and like that investigation, if you do a EEG, do you find any big differences?
EEG, sir.
EEG will show epileptic activity like spikes and sharp pace in intractable epileptic discharge in a poliodystrophy. In leukodystrophy, you can have a diffuse slowing. Do you understand? So at this point, you want to differentiate between a leukodystrophy. Now you know that you want to differentiate. You know the difference between a leukodystrophy. Now in this case, a case presenting with a development delay with regression and upper motor neuron signs and spasticity, what are all the differential diagnoses or prominent diseases that you will keep in mind before you go on to the examination?
Most probably among the neurodegenerative, I will put white matter disease as the most probable one. Sir.
What are the white matter disorders that you will consider?
So Alexander's disease or Canavan's disease, adrenoleukodystrophies.
Alexander, Canavan, and
Adrenoleukodystrophies.
then
Metachromatic leukodystrophies, Krabbe's.
one more. No, may not be much discussed in pediatrics, but much discussed in neurology. Another important disease that if you miss, it will be a very costly miss, because it's a treatable disease. Very much treatable. If not diagnosed, you may be sued in the court. What is that?
HIV.
Pardon? No, this is a disease which presents as a spastic CP, which is absolutely eminently treatable with simple drug. Quarter tablet of a particular drug can be given to treat the patient. Patient will have no spasticity, beautifully walk. It's an important differential diagnosis of any spastic CP. What is that? Yes, absolutely right. That is DRD. Never forget DRD, dopa responsive dystonia, and ask for history of diurnal variations. And you are supposed to try levodopa in all these cases when you are not sure of any other disease. Do you understand? Especially when there is no definite history of a perinatal injury. The child had no delay in birth. The child had no seizures in the first 24 hours of life. And if you are sure that there is no definite perinatal insult to the brain, and the child presents with spasticity, you don't miss one eminently treatable disorder, which is DRD, right? Never miss that. There are many cases which have been diagnosed at the age of 13, 14 and sued in the court in countries like UK. Never miss that. Eminently treatable disease. And in the history should include no diurnal variation in walking difficulty. Do you understand? So include that. So DRD should not be missed, right? And second, the list of ALD, MLD, Krabbe's, Alexander, Canavan. What are the two features of Alexander and Canavan that you can differentiate in the history? You mentioned about the head size.
So in Alexander's and Canavans, there will be macrocephaly.
Yes, they may have a larger head size. They may have that. Sometimes the patient's mother can say child's head size is larger, because since you talked about the head size, you can. Any other disease which can present with developmental delay and white matter involvement? Well-known metabolic disease, inborn error of metabolism.
Developmental delay and
Any inborn error of metabolism which can say an amino acidopathy which can present like a spasticity, which can present with human involvement. Don't forget about PKU also, phenylketonurias, right? So that can also present like that. So when you proceed with such a history, though you keep a wide list of disorders of neurodegenerative, any neurodegenerative in your mind, but keep in mind dopa-responsive dystonia, ALD, MLD, Krabbe's, Alexander, Canavan, PKU, all prominent disease in the list, right? Because they are the commonest spastic CP mimics, right? And never forget a DRD, right? With that you can proceed on to the examination, right?
I'm a little unhappy the way in which you landed straight on leukodystrophy. That means you got a clue. Here's a child which has illness has started at newborn period. If you think its whole thing is continuous, that's not the age where your leukodystrophy, type of leukodystrophy am I. So I would probably go a little cautious saying this child has got a development regression. I would like to consider the possibilities. One, a static encephalopathy with complications. Number two, recognizable inborn errors of metabolism, which I may be able to pick up at the examination. Third, neurodegenerative disease. And during the discussion, I'll expect you a little more details about neurodegenerative disease. Now, I think the pressure will fall on us. Quickly go on to the physical science. I think right now we are running on a grace time.
So on examination, the boy is averagely built. He was not very much responsive to comments. He gives simple laugh during the examination. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. His vitals, heart rate is 94 per minute, regular rhythm, normal in volume, normal character, no radial delay. Respiratory rate is 20 per minute, regular. Blood pressure is 100/70 in the left upper limb in sitting position, is afebrile. His vitals are normal. In head to foot examination, his head circumference is 49 centimeters, which is normal according to WHO chart, and his hairs appear normal, face appears normal, no obvious dysmorphism is noted. Eyes, no corneal opacity or cataract or KF ring. On fundus examination, suspected pigmentary changes with pale disc.
This is your findings or findings from the case sheet?
So I could make somewhat pale.
Give a description. Then why do you want to say Cori pigmentary changes? What did you find?
Pallor of the disc only I could find.
Only pallor of disc. Then why do you call it pigmentary changes? What is it? The reason why I am asking is pigmentary changes in the retina you may not be able to see without dilatation of the pupil. Whereas you say that you have seen pallor of disc and then you call it pigmentary changes. How confident are you on this physical science? Right, I think the CMC case sheet has influenced you too much. This is a problem. Once I give you a case with a known diagnosis, your thinking process totally gets stuck. What is the age of onset of the disease becomes crucial. If the age of onset you think is right from infancy, your differential diagnosis is different. Whereas if the age of onset is 5th year, your differential diagnosis is different. So you have to be careful and discuss both. Yes.
So no neurocutaneous markers. No painful swelling over the joints, no hyperpigmentation. So bones and skin appears normal. Anthropometry, weight is 16 kg, height is 110 centimeters, his BMI is 13.2, comes to nearly to -2 to -3 standard deviation Z-score, and it comes under thinness. So examination of the central nervous
system. So what's
system.
your impression about anthropometry? Normal or abnormal?
Abnormal.
All measurements should be followed by your comments. Normal or abnormal?
Abnormal.
What is abnormality? Because sometimes the pediatric examiners may go into details on this and not on the neurological. Be prepared. Whether it's acute malnutrition, chronic malnutrition, acute and chronic malnutrition. So because that will also influence how do you treat the child. Yes. We won't spend time for the lack of time. But
So examination of central nervous system, higher function, he is conscious. So orientation to time, place and person could not be tested, sir. Intelligence, yes, a subnormal.